It's a pleasure to be here to invite you all into the nice city of Düsseldorf. It's rainy today, so there's not much that's speaking against participating in the webinar. When there are any questions, just feel free to save them for the end. I will give you, or I will take my time to briefly answer them in the Q&A section. So just let's start with the radio frequency thermocoagulation for the trigeminal neuralgia. For me, it's quite, or to start again, I want to help you to get some tips and tricks to tell you how to do the procedure in the right way. And on the other hand, to get some help in getting the right indication and to check for the right patient to do this procedure. Because as you can see, I'm not only a pain specialist, I'm also a neurosurgeon, and except of the thing that we are just using a needle, I just say just using a needle, this is still an operation and you have to do it in a right way, in a proper manner, because otherwise this won't work, and in the it can go definitely in a wrong way. And we all need to do a proper therapy for all our patients to get them in the right manner. So just let's start. The important thing is that we think about the definition, what we are treating. So the definition of facial pain is one of the crucial parts in all this therapy. As you can see, this guy is surely having facial pain, but it's not that easy that when a patient who is entering inside of your ambulance, you don't see on his face, okay, he's having pain. He is telling you so, but it's very difficult to get the right patient and the right diagnosis, especially in facial pain. When we talk about the classical trigeminal neuralgia, there are some things we know and might to know. There's also kind of a synonym. It's called tic douloureux, as the people who are French speaking. Normally we see 12 persons per 100,000 persons per year, so it's not that often this diagnosis. We even in our specialized clinic in Düsseldorf, where we are in a university hospital, we see around about 1 to 2 persons per month, I think, with classical trigeminal neuralgia. So it's not that common. And normally the pain is in the distribution of the second and third distribution of the trigeminal nerve. Normally the ophthalmic division is very seldom. I think for classical neuralgia, I've never seen a patient who's also having some kind of projected pain in the first division. Sometimes you see them, but when he's saying it's mainly in the forehead in the first division, you have to be careful if it's not another another illness that you want to try to treat. At first, we need to go to the little bit boring part, I would tell. We need to learn what exactly is the pathophysiology and how the anatomy and the nerves are working. We still don't know exactly what is the reason for the occurrence of trigeminal neuralgia. There is by Rappaport and Devore the ignition hypothesis proposed, but it's a good hypothesis, but it's not, we can't take this for granted. But I want to tell you a little bit about it. It's the theory behind is that there is some kind of pathology that's induced by a kind of trauma or other things that cause a kind of deafferentation in a local part of the nerve. Normally, this results in a kind of hyperexcitability for this nerve, not only for the place where the injury is taking part, but also for the whole nerve. And this results in some kind of synchronized after discharge activity. So in the end, you have a nerve that's reacting very fast, very sensitive to trigger, not only from the nerve itself for sensory information, but also for trigger from the external part of the nerve for afferent reasons. And this results in the rise of pain paroxysms. So in the end, you have not only hyperexcitable nerves, so only small sensory information is resulting in a huge action potential, but also you have the originating of ectopic pacemaker sites. So in the end, not only when you have a real stimulus, you're touching the face, eating something, or anything that can trigger the trigeminal nerve. You also have sometimes pacemaker sites, so you have a spontaneous activity of the nerve. So in the end, what you have by patients, they say, I'm not doing nothing wrong. So and they're still coming pain attacks. This is one of the reasons cause the nerve is getting damage somewhere in the part, on the peripheral part or the central part, and they can trigger these severe pain attacks in the end. So all this together is resulting in a large in a small stimulus that is resulting in a large reaction and even a spontaneous activity of the nerve. When we do now ablative procedures on the nerve, what we try to do there is to destroy the neurons at the axons. So in the end, what we want to reduce the amount of nerve tissue that can be recruited by the ectopic neural activity. So in the end, you may have a spontaneous pacemaker site, you may have a trigger in the peripheral side, but the signal is not going after your ablation, and there couldn't be some kind of hyperactive reaction in the nerve. And this also prevents the cutaneous triggering. When there is no cable that is transmitting your stimulus, then there can't be no pain. This is when this is all working in the good manner. I tell you later on what is happening when this is not in the good manner. And what's really important for this thing is you still need to have a functional nerve. So when the nerve is totally destroyed, even when there are a spontaneous activity, even when you have some kind of cutaneous triggering, but when there is no cable present, you can't do any kind of ablation there. When we compare this to carbamazepine or the other anticonvulsive drugs, they're doing kind of the same, you can say. They try to suppress the ectopic hyperexcitability. So in the end, they try to reduce the active reaction of the nerve in the root and the ganglion, and this is also preventing the cutaneous triggering. You are touching yourself, or there's any kind of trigger, and in the end, there is a normal sensory information, but it's not resulting in this hyperexcitable reaction. This is not resulting in this action potential that is in the end triggering the pain in the central nervous system. So in the end, you can say we are doing the same with a different approach. As I told you beforehand, now we know what is triggering the pain itself. What we need now to know is how actual facial pain is working. There's not, you can't take facial pain for granted, as I show you now, because there are many reasons for the resulting in facial pain. You can have a direct nerve damage, as I told you before. It can be a trauma. It can be after an operation. You can have some kind of neurogenic dysfunction. There is the prime example is multiple sclerosis. It can have an idiopathic reason. You don't know. Genetic factors, some kind of autoimmune disease, you don't know. Trauma is always a thing we see in our practice, and also inflammation. And for this, we have many different classifications. And this is one thing you should consider in your practice. Use one classification. In our clinic, we discussed this several times, because in the end, we just had trigeminal neuralgia in the beginning and atopic facial pain. So everything that haven't been trigeminal neuralgia have been atypical facial pain, nothing else. And as you can see, there have risen some several of facial pain classifications. We use in our clinic the ICHD-3 from the international international classification for headache disorders from 2018, and this is the thing, our go-to classification. You can also use the old ISAP classification for chronic pain, but they are not that sharp for facial pain. ICD-11 is one of the most common thing we need in our practice to get the reimbursement done, but they also have a kind of classification for the facial pains. And the American Association of Orofacial Pain is also very good classification, but I think in the end, I I'm showing you the example from the ICHD-3. This is a very sharp classification. They go from classical trigeminal neuralgia up to the secondary neuralgias, and they all have classification for all kind of headache, facial pain, and you need this classification. Even myself and my colleagues in our clinic is frequently looking into this classification to be sure we're doing the right classification when we write our reports for the patient, that we don't say, it's trigeminal neuralgia. You have to be exact. This is one of the most crucial take-home messages. Get your classification done and get the right patient.